Good evening, everyone. As people join in, I want to welcome each and every one of you to the 15th episode of the Clinical Pathological Case Series. A case-based series that brings together emergency medicine aspects and perspective in low and middle income countries. So we are talking about Uganda and the neighboring countries as well, and Africa at large. And today we shall be discussing Is Unresponsive as the title. The Clinical Pathological Case Series is proudly sponsored by SIG Global Health, Ministry of Health. And remember that these trainings or videos in it are for educational purposes and should not be used as a sole source of reference during patient care. Always remember to refer to the official guidelines, both that are published by renowned bodies, and also the guidelines that are institutional based in your various hospitals and universities. Or consult a qualified personnel to guide you in the processes of managing these patients. Today, we are gladly joined by a couple of experts who will be dissecting this case that presented to an emergency department. From the pre-hospital team is Muhwezi Darius from St. Francis in Zambia Training School. And the case presenter for the day will be Dr. Akio Aloma, an emergency medicine resident in Hayawan from Kampala International University. And we shall be proudly hosting our international expert, the president of African Federation of Emergency Medicine, Dr. Joe Boni. He is an emergency medicine physician or specialist at Komfo Ankonye Teaching Hospital in Ghana. He will tell us if it's Accra. And CPC brings together students, intern doctors, medical doctors and specialists across the country and the globe. And the universities that we really target are Makerere International University, Busite Magulu, and all universities that can log in. Ladies and gentlemen, allow me to invite Darius to kickstart the process. You're welcome, Darius.
Thank you, Dr. Daniel. My name is Muhwezi Darius. I greet you, everyone. I'm doing my diploma in emergency medical care from St. Francis in Zambia Training School. I'll be taking you through the pre-hospital case, and this was a home facility transfer case where we used advanced life support ambulance, and it was a type C. And we were a team of 2 people. That was me, an EMT, and my emergency driver. Gloves, respirators, safety shoes, gown, face shields, and masks were called as personal protective equipment. Oropharyngeal airway, nasopharyngeal airway for respiratory support, including a suction device for clearing airway, and oxygen cylinder to help deliver oxygen and improve mild hypoxemia via nasal plums. Stethoscope, thermometer, and blood pressure machines were also called as diagnostics. We were dispatched to evacuate a female 53-year-old patient to the nearby hospital, which was Kampala International Hospital. On reaching, she had collapsed, lost conscious with 3 tonic seizures, and with altered mental status. Was hypertensive for 2 years, 1 week mild headache, dizziness, and blurred vision.
Muhwezi, could you please unmute? Darius, unmute, please. We lost you. Please restart the handover.
Um, Doctor, what did I get lost from the? We were dispatched to evacuate.
Yes,
To
please
evacuate.
carry on.
Yes, we were dispatched to evacuate a 53-year-old female patient to a nearby hospital, which was Kampala International Hospital. On reaching, she had lost consciousness with 3 tonic-clonic seizures and today with altered mental status. Was hypertensive for 2 years, 1 week generalized headache, dizziness, and blurred vision. Airway not protected, low GCS of 10, blood pressure 210 out of 123, heart rate was 90 beats per minute, respiratory rate was 24 breaths per minute, oxygen saturation was 90% on room air, RBS was 13 millimoles per deciliter afebrile. Recommendation: we recommended possible airway protection and further investigation and management. We suctioned the airway and supported with oropharyngeal airway piece. 5 liters of oxygen was administered via nasal plungs and achieved 96%. IV fluids, normal saline 500 ml was given slowly. IV paracetamol was also given 1 gram start to relieve the headache, and IV diazepam 10 milligrams were given due to active convulsions. A urinary catheter was inserted, which collected 900 ml on handover. I submit to you, Dr. Kiel.
Thank you very much, Darius, for initiating us through the pre-hospital and handover of the patient. And so the patient arrives to the emergency department, and the on-call team is Dr. Akio. Dr. Akio, please, can you carry on from there?
Yes. At the ED, we received a 53-year-old female in altered mental status with a urinary catheter in place and nasal prongs at 5 liters of oxygen. Primary survey, we had noisy breathing with an OPA in situ, as the EMT has stated. The neck was soft. The patient had labored breathing with saturation of 92% on oxygen muscle prongs. There were fine crepitation bilaterally. Her respiratory rate was 26 breaths per minute. Her blood pressure was 209, systolic and diastolic of 120 on arrival. The pulse rate was 90. Her GCS was 8 out of 15, and the pupils were 2 millimeters, equally reacting to the right. As mentioned before, the RBS was the same 13. A urinary catheter was in situ, and the volume was 900 mils of urine.
All right, thank you very much, Dr. Kio. And so from the primary survey that has been presented, we are just pulling up the poll, and you will be able to record your responses. What are the imminent emergencies that you would be thinking about? So you'll just briefly have a couple of minutes, let everyone participate. Fill in this poll. This will guide us in further guiding you here and after the presentation. The poll is displayed on your screen. All answers are correct when you answer it for the first time. All right, there is a good turn up of those answering. Those who are unmuted, please, you can mute and continue to answer the poll question that is coming through. Okay. All right, so people are still answering. I'm just giving you a couple of seconds to complete this. Perfect. So Dr. Akio, how did you manage
Yes.
this patient in the emergency department then?
Okay. Usually, while doing your primary survey, you address the situations accordingly. Under the airway, we elevated the head of the bed to 30 degrees, and we did suctioning of the airway due to the secretions that were present. With the labored breathing and saturation below 94 degrees, 94%, we put the patient on a non-rebreather mask, and saturation improved to 98% on 10 liters of oxygen. The patient was on a cardiac monitor. IV phenytoin was started. The patient convulsed, as we mentioned. The EMT gave her diazepam. So we started IV phenytoin 1 gram start, and we continued to monitor the patient as we continue with the intervention. The patient had been unwell for about 1 week. We generalized headache that was worsening over the 1 week, blurry vision associated with dizziness, and they mentioned that she had a total of 3 episodes of generalized tonic-clonic seizures with loss of consciousness. From our primary survey, we noticed that there was high blood pressures, and the patient was also tachypneic. She was hypertensive for about 2 years and was on nifedipine and hydrochlorothiazide. She collapsed, had convulsions that was generalized in nature, and was brought to the ED.
All right. Thank you very much, Dr. Kio. Audience, please, any additional information or questions you'd love to ask, please place them on the chat. We have part of the organizing team and the mentors to this case who are actively engaging with you on the chat. So please ask for any additional information as regards to the handover, the primary survey, and also the ample history, the sample history, and you will be answered gladly while there. At this point, allow me invite Dr. Joboni to give his opinion about the case so far. We can just move on to the next slide, please. Dr. Gioboni, you're welcome. What are your initial thoughts, and how would you prepare yourself as a physician on shift and your team to approach this patient? You're welcome, Dr. Joe.
All right, thank you very much. I think first and foremost, the very important part of receiving this patient includes paying particular attention to the information from the pre-hospital team. And I think they outlined the patient's condition very well, showing the high blood pressure. They talked about how the state of the patient was in, and then the initial assessment in the ED. So preparing your patients for receiving this patient, you need to know this is an unconscious patient who is coming in. And so having suctioning available, you should also be thinking very far down the line that depending on the GCS, maybe I would like to intubate this patient. Do I have a ventilator? Do I have space? Do I have ICU? All of those will need to be considered. You might not have to action on them, but you should be in readiness to be able to put this into play. For the initial presentation and workup at the ED, I think so far we are quite happy with what we have. It will be nice to see the results of the poll to see if everybody was in line with what's the possible diagnosis that we are looking at. There is obviously a high blood pressure associated with seizures. So our initial A, B, C, D as outlined, protecting the airways, making sure patient is breathing, SpO2, oxygen. And then at C, we would want to start with blood pressure control, and then disability, continue to monitor the conscious level. I'm not sure I've heard the current sugar level, or maybe I missed it. It would be nice to know the sugar level. And then also we haven't got any details about whether there are social related histories. Is there any alcohol related to this presentation? Thank you.
Thank you very much, Dr. Joe. And yes, Akio, you could just respond to any other points that have been mentioned there. What was the RBS, and was there any social history pointing towards alcohol use in this patient?
Okay, thank you so much. From the history we took, there was no use of alcohol or any drug abuse or smoking noted. The RBS was still 13 on arrival, as it was before arrival.
Great. Thank you very much, Akio. We could then move on to the secondary survey, please.
Okay, on our secondary survey, the jugular vein was distended. However, there was no pallor, no jaundice. There was lower chest wall indrawing, as mentioned earlier, with fine crepitations bilaterally. The patient was agitated. The muscles tone was hypotonic, and the neck was soft. The skin was intact. On log roll, there was no step-offs, no tenderness. So we had problem list. One, there was generalized tonic-clonic seizures, altered mental status. We had elevated blood pressure, systolic of 200, more than 200, hypoxia and crepitation on the lung, as well as raised intracranial pressure due to the severe generalized headaches, and also altered mental status. Yes.
All right, so as it is that we received a handover for this patient, initially we went through the primary survey, got the sample history, and went through the secondary survey. Our initial thoughts were really generalized tonic-clonic seizures, altered mental status. Please, there is a poll that we would love for you to again fill through. And what could be your differentials for this patient?
Is
You
it
can
possible
fill
we
through.
can see the is it possible we can see the previous slide once more?
All right, please let's go back to
Oh,
the previous slide as the poll is running.
I think the poll has moved to poll 3.
Oh,
I think that was
do we have poll two?
we changed the numbering. This is supposed to be the poll running. Sorry.
Okay.
All right, let's carry on. Let's all fill in the poll.
Hmm.
With a few seconds to go, I encourage everyone to participate. The poll is running and you'll just see it on your screen there.
Excuse me,
All
Dr.
right,
Screen.
in 3, 2, 1, we can end the poll. And at this point, Akio, what were your differential diagnoses? Initially, what were you working with as the diagnosis, and what were the differentials that you put together for this patient? Could you highlight us more on that?
So the patient had seizures, as we mentioned, came in altered mental status, had severely elevated blood pressure. The area is a malaria endemic zone. Of course, cerebral malaria was on top of the list. There was intracerebral hemorrhage, as well as intracranial tumor. We also had electrolyte imbalance. Ischemic stroke was also there. And as well as hypertensive encephalopathy.
Okay. Carry on, Akio. So you have the working
Yes,
diagnosis and you decide to investigate the patient.
yes. So we sent the patient for malaria test. We did renal function tests as well as electrolytes. We did a complete blood count and as well as a CT scan, head CT scan that was non-contrasted. That was the available imaging at that moment. Yeah, as you can see, the results of the laboratory, malaria results, RFTs, electrolytes, and the complete blood count.
All right.
So this is the CT scan, non-contrasted, that was taken of this patient.
All right. So we have our laboratory findings that the team had following the differential diagnosis that showed no malaria parasite seen. The creatinine was just slightly elevated above the normal upper limit of 83, but most of the others were within the normal ranges, as you could see. So there goes another poll for us. And you could go through and answer this in a few seconds. So the CT
Yeah,
scan is up there. You could just
yeah.
look at it as you
Sasa
answer the.
niko pale kwa duka ila karo nimekaa
Those who are
kuna
unmuted and
wana
talking, you could kindly mute. Thank you very much.
Is this the only view of the CT scan we have?
Unfortunately, yes, this is the view we could pick from the DVD that was playing. The poll is on your screen, so everyone could participate on it. All right. So thank you very much for filling up the poll. Akio, with the laboratory findings that you and the team had and the CT scan that was present at that point, was there any change to the index differential diagnosis that you had to this point?
I was able to do an exclusion and an inclusion criteria. As for the intracerebral hemorrhage, there was no blood or bleed on the CT scan. We saw that malaria was negative, so cerebral malaria was out of the list. In cases of intracranial tumor, most times the blood pressure may be normal and symptoms will be more chronic. And the type of seizures won't be generalized, but instead will be focal in nature.
Thank you very much, Akio. And Dr. Joe, many a times we health workers tend to have a small list of differential diagnoses, and we tend to anchor as well to the small list that we are having. From your opinion and experience working in the emergency department, are there any other differentials that you would really love to point out to us and the audience at this point? And what would be your management plan, given that we have all this information before us now? Dr. Joseph.
Thank you very much. So I love the first set of differentials that we had built. We had talked about cerebral malaria, a possible hypertensive encephalopathy, elevation of that into a hypertensive emergency, which could have been a cerebrovascular accident. There was, however, a differential of electrolyte imbalance. And usually what I would ask myself is, what will cause the electrolytes to go out of shape? We didn't have a report of excessive vomiting, excessive diarrhea, acute fluid loss. So usually electrolyte imbalance, I'll keep in my back pocket until the lab results are so glaring if we don't have any evidence of it. With the imaging, with the labs first, our malaria has been ruled out. Our vitals throughout, the parameters throughout. Yes, thank you very much. Um, so no bleed, negative malaria test, blood pressures, normal. So I think right now we still have our hypertensive encephalopathy high up on the list, but we cannot rule out our um strokes because although there's no bleed, there could be an infarct. Depending on the duration between when the infarct is and when the CT scan was done, you might miss it. So you still have to pay attention to the symptoms that you're having to be able to determine this. At this point, I might also be going back to the family to push a little bit to ask about previous seizures. Has he had seizures before? Is this the first seizure? And then also start asking about um some questions that will relate to either evidence of possible electrolyte imbalance, for which I might be thinking of considering doing an extended electrolyte screen if they point any of that out. So At this point, hypertensive encephalopathy still remains on the list. An ischemic stroke still remains on the list. And electrolyte imbalance would only pop up in case we are able to speak to the relatives and find out something that points to it. Thank you.
Thank you very much, Dr. Joseph. And yes, very, very importantly, how you have, Kyo, approached this patient. I would also, in your bedside investigations, it's very important, especially when a patient with altered mental status comes in, very undifferentiated for you at that point. You're suspecting stroke. You're trying to tease out the causes. A bedside ECG is something that would be very important for you to do. The patient could be having an AFib and perhaps is throwing up some emboli as well. Then still altered mental status, we could think about something metabolic. It's not clear in history. The RBS is 13. It could be stress hyperglycemia or reactive hyperglycemia. But doing a bedside urinalysis and looking out for ketones, this could be the first time you're diagnosing someone with DKA or diabetic emergency at that. Then in our setting, toxic alcohols are also a famous thing. So for advanced learners in this discussion, the residents and other health workers as well, picking out an arterial blood gas in the setting where you are and can do it would be some additive for you to try and tease out some changes in this. And then don't forget your point of care ultrasound scan. Again, if you're in a good setting, and just shine into the lungs, the heart, and the abdomen. You could be having something that you might get coincidentally for this patient who cannot communicate to you, and you're relying with collateral history. And so, Akio, with the expert opinion and the differential diagnosis you've given us, how did you then try to put this together in the ED? Dr.
Thank you so
Kyo?
much.
Yep.
Thank you so much for the additions, actually. Hypertensive encephalopathy with a flash pulmonary edema was the working diagnosis in a non-hypertensive patient. So we went about the definitive management of this patient. We noted our airway was not protected, and also the patient was agitated. The patient was intubated and put on mechanical ventilation. Hypertonic saline was 3% was started over 30 minutes due to the increased intracranial pressures. Labetalol was used in management of the high blood pressure. IV over 2 minutes, then an infusion of 1 to 2 milligram per minute. Reduction was targeted to a MAP reduction of 20 to 25% in the first hour. Then later it was lowered to 160 systolic and diastolic of 100 to 110 over the next 2 to 6 hours. IV Lasix was given, and phenytoin 250 was also given. NG tube for feeding. Glucose and temperature control was done. And our disposition plan was ICU admission for neurological monitoring, vital monitoring, and also drug administration.
Great. Again, thank you very much, Dr. Akio. And just to clear it, from your working diagnosis, this was a non-hypertensive patient who presented with a hypertensive emergency with 1, hypertensive encephalopathy, and 2, flash pulmonary edema. Dr. Joseph, at this point, given the working diagnosis that we have, what could be the pearls and pitfalls for the management of this patient, or even rather coming down to a diagnosis of such in the emergency department? Dr. Joseph.
All right. So thank you very much. So hypertensive patient has been established from the history. So I appreciate the fact that we always give a composite background when we're given the working diagnosis in the emergency department. So that is always a peril, that give the background in the one diagnosis so that people don't have to struggle to remember what you are talking about. And then we go on to present, to give the presentation of a hypertensive encephalopathy. That is also very clear. We have seen the progression throughout. What I find missing is we have established some raise in intracranial pressure within this conversation, and that was missing. So when you start to list the complications, you will need to be exhaustive to ensure that you capture that there's raise in intracranial pressure. Since we are the generation of the ultrasounds, I think somewhere before this, if we had done an optic nerve sheet diameter to measure the optic nerve sheet, determine that it is above 5 millimeters, then we would have also been able to determine that this raise in intracranial pressure is confirmed by a bedside ultrasound. So the pitfalls are for this is, do not use just the information. If you do have the tools available, please reach out. I think someone already talked about the fact that you needed to use the ultrasound. So please, let's use our ultrasound. With the flash pulmonary edema, I might be the only one that might be missing it. I wanted to find out if you could tell me a little more why we zoned in on just that one for the chest. For the if we could go back to the management so that I can comment on that.
Could we just slide back to the management that was given, please? Yep.
Excellent. I think so far I'm comfortable with all of this. For a patient who has come in with the initial seizures, I will want to speak about the NG feeding, but be cautious to state in the notes that they should only be feeding this patient when they have realized that the seizures have been stabilized. So that the instruction is not taking at wholesale and then people are feeding probably immediately after a seizure or so. For your glucose and temperature control, if you could give targets so that people can work towards those targets, that will be beneficial. For us to state that there was a flash pulmonary edema, I do believe our level of Lasix could be adjusted. I am a little bit less conservative. I would have gone with an 80 milligrams and then a 40 milligrams twice daily, paying attention to the blood pressure. This position is excellent. We don't want this patient in the ED anymore. The ICU should take over. So those are my discussion points on the working diagnosis and the definite management. Back to you.
All right. Thank you very much, Dr. Joseph. And for those who joined in a little bit late, we have been discussing a 53-year-old female who presented with altered mental status. She was brought in on nasal prongs and 5 liters of oxygen. Evidently, she had very high blood pressures that were controlled in the emergency department. A couple of investigations were done, including labs and CT scan to rule out and rule in some aspects of his or her diagnosis. And finally, the team zeroed down on a known hypertensive patient with hypertensive encephalopathy and also flash pulmonary edema. And we are so glad for the dissection that our expert has given us on the pearls and pitfalls for this patient. And so, Dr. Akio, you could take us through briefly the discussion.
Okay, thank you so much. Okay, at the ED, we receive patients with elevated blood pressure. It's important to differentiate what kind of patient you're dealing with. We have patients with only markedly elevated blood pressures with no target organ damage. The diastolic could be above 110. In such patients, you just give oral antihypertensives and an outpatient follow-up. While in cases of hypertensive emergency, we have blood pressures that are elevated, diastolic of more than or equal to 110, plus acute target organ damage. These patients require IV therapy. But hypertensive emergency should not be looked at. We don't look at the blood pressure only. The blood pressure should not be our target, but what we should look into is this patient having a target organ damage or not? For example, we have a patient with a systolic of 116 and a diastolic of 100, but came in altered mental status and had seizures. In such cases, we treat it as an hypertensive emergency. So let's not have the notion that hypertensive emergency should be tagged with a specific elevated blood pressure, but instead it's mainly acute target organ damage plus elevated blood pressure with no specific levels. So a pathophysiology of hypertensive encephalopathy, when we have acute blood pressures, we lose the cerebral autoregulation. We have cerebral vasodilation that leads to endothelial dysfunction. Blood-brain barrier is broken down, and vasogenic edema that leads to increased permeability and increased ICP. Hypertensive encephalopathy and treated early, it is very reversible and outcomes can be good. How do we recognize hypertensive encephalopathy? Clinically, patient, in our case, the 53-year-old was agitated, had generalized severe headaches that was worsening over 1 week. She had seizures and she had visual disturbances with reduced GCS. In some cases, some patients can be confused and also have vomiting. Fundoscopy, when done, will see papilloedema, retinal hemorrhages, and exudates. Our investigations is either a brain MRI. If it's not available, we can choose non-contrast CT brain. To look at target organ damage, like the kidneys, we look at the RFTs, the renal function test, the electrolytes, the creatinine, the urinalysis. And for the heart, myocardial infarction, maybe we look at the ECG and the troponin. While for pulmonary edema, we do a chest X-ray. One thing we have to be careful about is blood pressure reduction and targets in the ED. Due to the auto cerebral regulation, when we have chronic blood pressure, there's a tendency of having a right shift of cerebral autoregulation. So when you have acute increase in blood pressure, it's important to start lowering the blood pressure slowly so that you don't end up causing more harm to the patient. So initial target is within the first 1 to 2 hours,
They are
use
very painful.
not more than 20 to 25%.
Right.
While in the next 24 hours or 2 to 6 hours, we gradually reduce towards a systolic of 160 and a diastolic of 110, 100. And we can reduce the blood pressure further to normal over the next 48 hours. We have exemptions whereby we have to aggressively and rapidly reduce blood pressure in cases of aortic dissection. Drugs of choice when it comes to blood pressure reduction in a hypertensive emergency is IV sodium nitroprusside, which needs close monitoring. So you can consider using IV labetalol as a bolus or IV nicardipine. IV nitroglycerin is used in cases of pulmonary edema, and in mothers who have eclampsia, IV hydralazine is most recommended. So how do we go about management of hypertensive encephalopathy? One, if the patient comes to the ED, we recognize life-threatening conditions from our primary survey. So you address whatever condition that you find, airway, the breathing, the circulation, and also glucose management. You control the blood pressure. As we mentioned, we gradually reduce the blood pressure. Seizure control, if it's active convulsion, you can use benzodiazepines and later maintain the patient on phenytoin. ICP control, we can use hypertonic saline or mannitol. And finally, disposition plan is always ICU care for neurological monitoring, for vital monitoring, and also drug administration. Yes, thank you so much.
Great. Thank you very much, Dr. Akio. And I believe you had a mentor you were working with, Dr. Brian. If it is possible, could you just unmute? And if there is anything you'd love to add for the audience, I would be glad for you to come in at this point. Dr. Brian? Well, as Dr. Brian is preparing to come through, just a couple of ads that I would give you, especially the students, is that when we approaching the patient with altered mental status, sometimes we do not have the family or collateral history coming in, and it's just a neighbor who picks up this patient to come in. I will always remind you to go through a couple of mnemonics. There are two famous mnemonics that we use, A, E, I, O, U tips, but also the simple one is DIMES. So DIMES is DIMES, where D stands for drugs. So these drugs could be, it could be side effects of drugs, it could be drugs of abuse or sedation. And then alcohol is also a drug that you have here. It could be alcohol use disorder. So a patient comes in altered cause of intoxication or withdrawal in itself, or any other overdose that could have affected the patient from medication. Then I is for infections. So we ruled out cerebral malaria here, but then you could also think about encephalitis, meningitis, syphilis, neurosyphilis at that. And for the elderly, it could be a focus of urosepsis, giving them altered mental status, or pneumonia, community acquired or even hospital acquired pneumonia. And then M being for metabolic, and here you encompass the metabolic aspect with endocrine. We talked about electrolyte imbalances here. You can talk about hypoglycemia, endocrine disorders like diabetic ketoacidosis, thyroid dysfunction, or emergencies that can also be there. And then E for electrolytes, and then S is a structure. Here we looked into stroke, but it could be that the patient fell down and got acute epidural hemorrhage or subdural. Or it could be that there's a tumor that is now, expanding and has made the patient present with altered levels of consciousness. So I encourage you in your emergency department, just write this down, spread it down, and just try to tick off what have I assessed, what haven't I assessed in your emergency department. Many a times, this really helps us to bring this patient into order, especially while investigating and ruling in and ruling out. And then secondly, I also encourage different cadres and health workers to again just write down first hugs in bed. It's again a mnemonic that encompasses supportive care for this patient. Just like the definitive care has been given us here, many other things will be done. And before I invite the expert for his closing remarks and take home, I would love to again thank the team behind the productions of the clinical pathological case series, Seed Global Health. As you can see, the wall of fame there with various people who have been with us discussing today. This is the 15th episode that we are on, and we are going. And big breaking news is that for these cases, you can access them on YouTube. They are there. We record them, we upload them for you to go back and follow step by step. Importantly, we have an upcoming CPC podcast. It's a podcast that brings together the brightest minds across the globe, Africa, East Africa, and Uganda. But we are saying many podcasts outside there are talking about emergency medicine, are touching aspects that we might not see readily in our environment. And so CPC is trying to bring this podcast to highlight to you what occurs real time in a low resource setting and how we can improvise and think through the setting. So watch out. In March, we shall be having our episode. This is also going to be another episode for us to record, and many more shall be coming through. So brace yourselves for impact. It's really a season for you to learn and blossom. Knowledge is power. It's only the key. I don't know to success, but it opens doors only God can open. So thank you very much always for coming in. Before you log out, allow me invite Dr. Joseph Boni, again, all the way from Ghana. We thank you for sacrificing um, your time for us. We are so glad. We know you visit Uganda from time to time and you love us. It's this love that we are sharing today with different students across the nation and internationally. And because of the love you give us through African Federation of Emergency Medicine, here we are today, growing bigger and bigger. We started, I think our first episode had about 18 to 20 participants, and now we are blossoming on 153 and counting. Dr. Joseph, you're very welcome to give us your closing remarks and the take-home points. Thank you.
All right, thank you very much for this. This is my first time attending such a session, and I am blown away by the methodology that is being used here. This is phenomenal, and I believe this is something that Uganda can hold up high for how they have been able to run this and make it so successful. We will look forward to seeing maybe an academic paper around how this is run, how many sessions and its impact moving forward. AFM is very happy to see the growth of emergency medicine on the continent, and Uganda has been a shining example for being able to build a very strong emergency medicine system. With this, I would like to also throw a big invitation to all of you for the next up and coming African Federation Conference Medicine. It will be happening in Tanzania from the 11th to the 13th of November. I have 147 people on this call. All 147 of you should make it an effort to be coming for this conference. It promises to be wonderful. We know how our brothers in Tanzania can make it happen. So please join us all to come and celebrate emergency medicine. And I believe such case presentations can actually be a feature at some of the stalls where people can walk in, get a simple diagnosis, and then we can keep a poll that runs throughout the whole conference, and at the end show the results of who got some differentials correct and so on. I think it'll be exciting. It'll be something great for Seed and the teams in Uganda to build up. Thank you very much, and I'm wishing you a wonderful weekend and happy new month in a couple of days. Thank you so much.
Thank you, and thank you very much, Dr. Joseph. We are all smiling, and because of the smiles we are having, we are actually going to have a screenshot with everyone just putting their picture through, and we celebrate with our president, African Federation of Emergency Medicine, for joining us. We really love this. So everyone, let's just bring our faces through. We are going to have a screenshot for this moment. I hope mine is also clear. It's winter here in Uganda, actually.
We can see you, sir. Thank you, everyone, for the session, and we look forward to hosting you more and more. And a big thank you to our president, Dr. Joe. Thank you so much for accepting our invite. Really big encouragement to us.
All right, everyone. Thank you for having attended this session. We normally try to keep our sessions within the 1 hour period. Please, if you have any questions, keep them coming. And in the last few minutes, I don't know if Jimmy, you can share the poll for those who are still around, the results of the poll. Those who have attended, tell a friend to tell a friend that emergency medicine is only getting easier and simple. We are trying to break this down to the simplest and basic knowledge that you can actually try to kickstart your first day in a busy and chaotic emergency department. We, as emergency medicine practitioners, are renowned for putting chaos into order. So in everything that we do, we just want to make people feel calm, respected, and excited in that room. Thank you very much for attending. Subscribe on the YouTube, follow the podcast that is upcoming. We shall be hosting experts, and Dr. Joseph will be part of our near future as well. Thank you very much, everyone.
We have a post-test poll that is running, and then we shall launch the results of the poll. I'm going to briefly share the CT scan so that those who could have missed can get to see how the CT scan was looking like.
I don't know.
Thank you very much, everyone, for always sparing your 1 hour. We have CPC cases going on every month. We try to bring the cases that you see in your hospitals. If you have an interesting case, reach out to Big Jim. Big Jim is the one running the show behind the cameras and the internet. Reach out to him. Feel free to present your case. We shall always avail mentors for you, either within your hospital or volunteer emergency medicine physicians. Let's grow together. It's only fair for the region to have a balance in the knowledge and approach to the emergencies in the country. Thank you very much to our presenters today, Darius, Akio, and Dr. Joseph. We are so grateful. And please open your hands again and your minds, most importantly, for our next invite. Thank you very much. Exactly
Right, so
8 p.m.
I'm launching the poll results, then we can call this to an end.
Thank you very much, Jimmy.
So for question 1, maybe Dr. Danny, if you could take them through what the correct answer was.
So question 1 quickly was that from the primary survey, what are the imminent emergencies? 35 out of 36 answered, and the correct answer was the threatened airway. Especially we know that A, B, C, D So the first things first, airway could be the one that would result into this patient getting hypoxic and cardiac arrest. So yes, threatened airway, we need to manage it. Next poll question. Jimmy,
Yes.
next poll question, please.
Oh, I thought I'm sharing. I'm actually currently sharing question 2.
Okay.
So question 2 reads, okay. I think I got, yeah, has it come up?
No, we're still on question 1.
Yeah.
Scroll upwards. Scroll. Do the scroll
Oh,
button.
yes. All right. So question 2 is there. When you scroll through, what are the pathological findings from the CT scan? And so we had the CT there with lots of findings that we're interested in, but there was global cerebral edema. This was evidenced by the loss of the gray-white matter differentiation, and then there was also thinning out of the sulci. So those folds that create the space in between there, we call them sulci or sulci. So there was also loss of the sulci and gray-white differentiation was the correct answer. And question 3. What are the differential diagnoses for this patient? And we elaborated that in the presentation: hypertensive encephalopathy, ischemic stroke, cerebral malaria, electrolyte imbalance. Remember your DIMEs, mnemonic. Those will be your differential diagnoses, and so that you roll in and roll out. And when you get the right one at the end of the day, you dispose accurately to the patient, to ICU or any other discipline. Yes. So thank you very much, Jimmy, for sharing the post-test results with us. And to everyone, good night, and we love you all. Please follow up on YouTube and watch out for the upcoming podcasts. We shall share links with you, and everyone could be able to listen in. Goodbye, everyone, and have a lovely night. Happy weekend. It's a Friday.